Today I would like to discuss otosclerosis and Stape surgery. There's a condition that's very common in white Caucasian people where bone begins to grow in the inner ear in a number of patients. In our temporal bones, we see the otosclerosis occurring in 1 out of 8 people. This is a very common condition, but actually in these people, only 1 out of 10 will it become clinically significant, where we will see a hearing loss, which is usually conductive in nature because of fixation of the little stirrup bone, which I will show you shortly. This is a hereditary type of condition. It runs in the families. It's more common in women. Usually when the patient is going through childbirth or pregnancy, the hearing gets worse because of the hormonal effects on the otosclerosis. And the hearing usually slowly decreases over a period of time. It's common in both ears, can occur in one ear, and it can be corrected by 2 surgical procedures that I'll tell you about now. Okay, we're going to discuss stapedectomy with a prosthesis first. The patients are taken into the operating room and actually placed under general anesthetic. The procedure takes about 1 hour. Here you can see the microscope. This blue line here represents a laser going through the microscope. Actually, we use the laser by holding it in our hand much like a pen now and doing the surgery with the laser in a handheld instrument. We use a speculum placed in the ear canal, and then the incision is made in the skin of the ear canal, and the canal skin is elevated with the eardrum much like opening a book. When we open the ear, here we can see the incus, the little stirrup bone, the stapedius tendon, the round window, and you see a white material here. This is the otosclerosis that is fixing the stapes bone. What happens when this occurs is approximately a 20 to 40% hearing loss because of fixation of the stapes. If it's fixed completely, obviously it causes more hearing loss. Because the otosclerosis is growing in the cochlea, the enzymes from the otosclerosis can cause a sensory neural or nerve type of hearing loss along with the fixation of the stapes. So many times the patients have a nerve loss along with the mechanical loss of hearing. For this nerve loss, we ask the patients to take sodium fluoride 1 milligram a day for many years, which has a tendency to stop this otosclerosis from growing. We then take a fat graft from the earlobe. We inject the ear with a little xylocaine and adrenaline, and then remove a tiny piece of fat, which we're going to use to seal the inner ear after doing the stapes procedure. This procedure was actually developed by Dr. John Shea in 1958. We began using the laser in about 1983. Since we've been using the laser to do this procedure, the results have been quite excellent. The scarring has been much less, and the symptoms, the post-operative symptoms, have been reduced. Here you can see small dots here where we take the laser and make what we call a rosette. This vaporizes the foot plate of the stapes, which is fixed, and allows us to have an opening through which to put the piston. Here you can see the piston that's going in place, and we tighten that piston around the incus. We've used for many years a stainless steel and Teflon piston. For the past 2 or 3 years we've been using the COS piston, which is entirely of plastic, and it is much more kind to the incus and causes less damage than the wire does over many years. And we like this prosthesis very much. Here you can see at the bottom picture, you can see the prosthesis in place, and here is the fat that we're placing around the prosthesis. This is a little plastic piece that I've inserted to prevent adhesions from the eardrum or the incus from around the prosthesis. This is made of silicone. We then put a little piece of fat over the COS prosthesis and then close the eardrum. A little packing is placed in the ear, which lasts for 1 week and then removed in the office. Four or 5 years ago, in 1994 to 1995, I developed a procedure which I call the laser stamp procedure, which is a laser stapedotomy minus the prosthesis. This is quite an advance because we can now restore the patient's hearing without using a prosthesis. Unfortunately, it only can be done when there's minimal amount of otosclerosis, fixing the stapes, and the patient has a nice blue foot plate. This occurs in about 40 to 50% of the cases where we have anatomy that allows us to do the procedure and minimal fixation. What we do is take the laser and make 2 cuts, one right across the foot plate and one right across this stirrup, the anterior cruce. What that does is it separates the mobile portion from the fixed portion of the stapes and preserves the patient's tendons, the pediis tendon, and actually preserves most of the patient's normal stapes. The hearing is then becomes normal, and the patient, we then take a small piece of fat adipose tissue and place it over this opening, and the patient leaves the hospital. This is a minimal surgery for minimal disease. Their surgical trauma is reduced by using this procedure. Most of the patients have their normal stapes preserved. Prosthesis problems are avoided, as in doing the piston procedure that I talked about before. That occurs in about 10% of cases that we have a problem with the piston or a prosthesis over time. We reduce the amount of trauma to the inner ear. Patients also, by having their tendon here, have acoustic and barotrauma or pressure trauma to the inner ear reduced. And the patient may have more normal hearing when the tendon and most of the stapes is preserved. Also, they complain less of noise intolerance after the surgery. The results of Stape surgery have been very excellent throughout the years. We can restore the conductive hearing loss in over 90% of the patients. Of course, we can't treat the nerve loss that the patient has, but the ability to create a normal conducting middle ear greatly helps the patients hear. We're very excited about this procedure. Fortunately, the complications have been infrequent. Occasionally, patients will have a hearing loss from the procedure, from any stapes procedure. This occurs in about 1% of patients, either due to an infection or an unknown cause, so that there is slight risk to the surgery, but the benefits far outweigh the risks in this procedure. Thank you.
Hi, welcome to the Ear Research Foundation. I would like to tell you about our foundation that was started in 1979. It's now 20 years, and the foundation has been a dream of mine since starting early in medicine. The purpose of the foundation was to establish a place where research could be done to improve patients' hearing, and also to improve patients with dizziness and with imbalance. We have made great strides for the last 20 years. The other parts of our program have been education and also treatment. We have actually run out of our facility space, and we need a new building. And we're going to start construction shortly on a 3-story, 22,000 square foot building on the property that's owned by the foundation on Floyd Street. This building will hold the Ear Research Foundation the laboratories for the foundation, administration, the research area. It will have the Florida Ear and Sinus Center offices, an outpatient surgical facility, and the medical hearing aid systems department. I'd like to tell you a little bit about what we've done in the past 20 years as far as our accomplishments go. We've seen over 27,000 patients in our clinics. 9,000 of these have been children. We've done over 2,000 surgical procedures on patients. This clinic is an indigent clinic where patients can come where they can't afford the private physician. We've done cochlear implants for totally deaf children in 15 cases where we've found funds and helped subsidize these children who have no funds for their surgery and rehabilitation. In the early 70s, we were one of the first to talk about conservative management of acoustic neuromas. Another thing that I developed at the Ear Research Foundation in 1985 was a device called the Silverstein Facial Nerve Monitor. This has a little clip here. It's a very simple device that clips onto the mouth, and whenever the facial nerve is stimulated, the mouth moves and a bell rings inside this monitor. This is a little handpiece that has a probe that you can stimulate the facial nerve during surgery. We have used this in every case since 1985. Over 2,500 cases have been done with this monitor. And we have saved the facial nerve in many cases where it may have been damaged without the use of this monitor. Now let's talk about Meniere's disease a little bit. In 1978, I developed a procedure to correct and cure the vertigo of patients with Meniere's disease. Meniere's disease is a disease where the patients have recurrent episodes of vertigo, hearing loss in one ear, balance difficulty, and also ringing in the ears. The procedure that I developed is done behind the ear. We remove some of the mastoid bone, open up, and we can see the nerves going from the inner ear to the brain. We can see the facial nerve here, we can see the cochlear nerve and the vestibular nerve, which is cut in this case. When you cut the vestibular nerve, the patient no longer has any more vertigo spells. They continue to have their Meniere's symptoms of pressure in the ear and ringing, but their vertigo attacks are completely relieved. These patients are very, very happy for the surgery. We've done over 250 of these procedures since 1978. The results have been excellent, and the complications have been infrequent. The micro-wick was developed about a year ago. This is a small wick that we place through the eardrum after we put a vent tube in the eardrum, and I'll show you a picture of this shortly. This wick goes down and is attached and lays against the round window membrane. The patient then treats themselves with a dilute solution of gentamicin, 3 drops 3 times a day for several weeks. The drops go down the wick into the inner ear and slowly destroy the balance center and preserve the hearing. This has become a very successful treatment, and actually the number of vestibular neurectomies has decreased dramatically in the last few years since we've been using this conservative technique that we've developed that can be done in the office. In about 40% of the patients with otosclerosis, there's minimal otosclerosis, just fixing a small portion of the stapes in this area. What I've developed is a simple procedure with a laser where we cut the foot plate of the stapes here, and we make a cut here. What this does is it separates the fixed part of the stapes from the mobile part of the stapes and preserves the stapedius tendon here. This is a minimally invasive procedure, and what happens is this part of the stapes becomes mobile and the patient's hearing returns to its normal state. For the past 15 years, I've been studying jazz, piano, and I've made 5 CDs. The reason I'm telling you about this is because I've used these CDs as a fundraiser for the foundation. We've been very successful to this date and have raised $40,000 giving these CDs away to our patients and our friends. That's a rundown on a number of our accomplishments, research, developments throughout the past 20 years. We're looking towards the 21st century to make further breakthroughs in medical science. I would like to say that I'm very proud of the 24 fellows that I've trained. These doctors have gone throughout the country, and many of them are in academic positions and are professors in their department. So that's the story of the Ear Research Foundation here in Sarasota, Florida. We're very excited about the new prospects of our building and for the new developments in the 21st century for research, education, and treatment of our patients. We hope that you would like to join us and become members of the Ear Research Foundation and make donations to our new project. If you'd like information, you could call us at 366-1148, area code 941. Our webpage is www.earsinus.com. Thank you and goodbye.